Hello and welcome. I'm Steve Clemons, editor-at-large of The Hill. Thank you for joining us on day 3 of the Republican National Convention. This morning we heard from lawmakers, pollsters, and the Republican National Committee about topics that are front and center for the American voter. And now we will discuss what continues to be a major factor on the campaign trail, the continuing COVID crisis. As Election Day approaches, the COVID-19 pandemic remains an ever-present threat. The U.S. has now almost 6 million cases, nearly 180,000 deaths due to this virus. In the midst of this health crisis, medical professionals and hospitals, particularly those training the next generation of healthcare providers, are on the front lines and were some of the first to adopt innovative methods to overcome the challenges brought on by COVID-19. Today, we're going to be speaking with policymakers and medical experts about lessons learned from the coronavirus pandemic and how we can build a more responsive and resilient healthcare ecosystem moving forward. I'd like to thank our sponsor, the Association of American Medical Colleges, for their support of today's event. Before we get underway, a few housekeeping notes. You can tweet us at @TheHillEvents using the hashtag #TheHillCovid. We're broadcasting live and we'll be taking your questions throughout the program. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guest today is Congressman Michael Burgess, who is a member of the Energy and Commerce Committee, where he currently serves as the ranking member of the Health Subcommittee. He is a physician himself, so we're looking forward to hearing from him on a topic that is on everyone's mind. Representative Burgess, it's great to see you. I not only know that you're a physician, but you're like the physician in the House. You've been at this, for many years. You had a distinguished career in medicine. So if we were to ask you today at this moment, as you look at the state of healthcare during the pandemic, what would be the features of it you think are most important to note?
Well, I think certainly you've got to be impressed by the way the healthcare system has stood up and battled this pandemic, not just in the district that I represent, not just in my state, but around the country, continually meeting and talking with people who have really been on the front lines of this. It hasn't always been easy. The path forward has not always been straightforward for them. The directions from the various federal agencies have not always been consistent, but what has been consistent is the heart and the caring on the front lines of our health professionals.
Well, you were trained in a medical college, I assume. You were part of the system we have. We're going to be talking to lots of medical centers and researchers. And I'm interested, in this world, because they're not only treating patients, they're also training the next generation of healthcare workers that will be on the front line. What are your insights from that as you legislate and you think about what's needed out there? What do they need that we're not hearing enough about?
Well, one of the things that really got my attention, I guess it was March or perhaps early April, in the state of New York, where I think the decision was made that, hey, this year's crop of medical students that is fixing to graduate in a few months, we could actually put them to work and basically use them as medical school graduates, as licensed physicians. And that was, I think that spoke to the overall flexibility that is in the system. You need capacity, and there are places where you can go to achieve that capacity. That's one of the things I've worked on for years in our trauma system, and how to collaborate between our teaching hospitals and our military physicians. We had the experience down here in Dallas at Parkland Hospital with a shooting that unfortunately took out 5 policemen about 4 years ago, and the Mission Zero Act was what came out of that. But I remember thinking that attack took place, so that tragedy took place on July the 7th of 2016. When you stop and think about July 7th, that's the end of the first week of someone's internship, someone who the week before was a medical student. And yet the personnel at Parkland ER, the Baylor ER, where the officers were taken, behaved in an exemplary fashion, which is one of the things that really pointed to me that there is capacity there that we may need to call on in times of crisis, and the capability is there, and we should have the tools in place to be able to call on that.
Does it feel to you, Congressman, that we are through the worst of this crisis? I've listened carefully to words spoken at the convention this week, and many of the speakers are talking about COVID in the past tense, which was a surprise to me. I'm not I'm not saying that others in the Democratic side haven't done it, but I'm just wondering, is this feeling as if we've kind of reached peak COVID and we're coming now down on the other side? Or do you think we need to continue to be, very serious, on the alert, kind of continuing to see how this thing comes at us?
Well, and as you know, Steve, it's been different in different parts of the country. Obviously different in New York and New Jersey, where their peak really occurred sometime in the latter part of March and the early part of April. Texas had an onslaught in April. It appeared to calm down, and then through the month of May, it seemed relatively stable. And then about the middle of June, cases began to increase, and in various parts of the state, the increase continued until about the second or the third week of July, and since then has trended down. So the trend lines are certainly going in the right direction, but I think that experience taught me that this wasn't truly a second wave. This was the continuation of the first wave and finding more vulnerable people to infect and for the virus to propagate and do its damage out in the community. But yeah, you've got to be careful with this thing. And the whole purpose of the Republicans on the Energy and Commerce Committee has been to work on what needs to be in place for the second wave. If a second wave is indeed poised to happen, what do we need to do to be ready for that second wave? I've been a little disappointed the Democratic leadership in the committee has not been as receptive to having that type of discussion, but I know the subcommittees of both health and oversight investigations have put a lot of work into reports that they've made public on what the prospects for a second wave and what the outlook for a second wave. And then we all know on top of it, we're likely to have just the seasonal flu. It always peaks about that same time. But here's the other part of the story, the reason I'm so optimistic. I do truly believe I've never seen anything quite like what's happening with Operation Warp Speed. The scientists that are involved, the depth of their knowledge, their dedication. I do believe by the end of October, by the 1st of January, somewhere in that time frame is going to be not one, but likely 2 or 3 vaccine candidates who have made it through with FDA approval. Something I'm seeing with this infectious disease that I've never seen before is the FDA has agreed to allow the manufacture of doses of vaccine. Can't be sold until it gets final approval from the FDA, but they could go ahead with the manufacturer. In contrast to 2009 when we had a bad swine flu epidemic, yeah, great, we got the vaccine and we were all worried about starting school, and then 1st of October we got the vaccine, but there was none on the shelves, and it took the rest of the month of October to begin to ramp up production. This time there does seem to be that notion that we've got to be ahead of this curve. We've got to have those doses of vaccine available for when that approval is given by the Food and Drug Administration. Is there a risk there? Sure, there's a financial risk that the company is taking. There's not a risk to public health because no vaccine is going to be released or used until the FDA has certified that it is both safe and effective.
Look, what you've just said, Congressman, it sounds really important to me, and it's something I had not heard before. I've recently interviewed Dr. Redfield of the CDC, and he said the same thing. We're going to face not only whatever second wave is coming from COVID, but also the combination with the flu, and it's going to create massive challenges and pressures in the healthcare system. And are you saying that, you're the Republican leader of the Health Subcommittee of Energy and Commerce. Are you saying your Democratic leaders on that committee are not seeing that coming and are not taking action now?
Oh, this has been frustrating to me the entire time since I first heard about this these pneumonia cases that were occurring in China. I was concerned about this right from the get-go. Not that I was in any way had the ability to forecast or foretell what was going to happen, but for a country like China to shut down a city of 10 million people in January, that's the month of their Lunar New Year. It's a month of great celebration in their country. And they shut it down. I've never seen anything like that. I've never heard of the city of Wuhan, China, to be perfectly honest. And the city of 10 million people is completely shut down. I knew we needed to take this seriously. I knew what they were seeing on the ground had to be pretty devastating for them to take that type of action. Yeah, I communicated that concern to the White House. I like to believe that concern was one of the factors in creating the travel ban that occurred from mainland China. Now people in retrospect saying, well, it wasn't soon enough and it wasn't severe enough, but at the time it was pretty roundly criticized, as I recall. But more to the point, we just passed the year before a bill called the Pandemic All Hazard Preparedness Act, the very bill that was supposed to be on the lookout for this type of problem. President signed it into law in June of 2019. This thing hits the following January. In February, I recommended that we have some real-time. Look, this is a real-time oversight. We just passed this law, it just got signed into law. Is it doing what we thought it would do? Is it behaving like we thought it would behave? Did we cover the bases we intended to cover? We never asked those questions. We had hearings on flavored tobacco, horse racing, ticket stubs, all sorts of things, but never had an oversight hearing on this problem. In fact, I was criticized for even bringing up that we might want to have such a hearing. We eventually did at the end of February as a very brief add-on to a budgetary hearing. And then really it wasn't until March that the committee seemed to want to get serious about this. But then Congress disbanded and basically we've been remotely focused ever since.
In a short few moments, I'm going to be discussing the Association of American Medical Colleges playbook for thinking about what to do in pandemics. And one of the items that caught my eye, which I know you're interested in, is how do you reform the national stockpile? And, we were we were mugged essentially by the COVID virus. This showed lots of deficits, both in planning and distribution and materials themselves, concerns about the global supply chain and where we get these materials. So how are you thinking about reforming the national stockpile and the importance of that?
It will involve additional scrutiny on the supply chain. Look, we can't just change everything overnight, but there does need to be a focus on reshoring a number of those activities. Strategic national stockpile, we did finally have a hearing on that well into the pandemic. We heard from Greg Burrell, who was the former director of the Strategic National Stockpile. I think one of the revealing things to me was that amongst members of Congress, there was the concept that the SNS would actually is the sole provider for any type of needed medical equipment anywhere in the country at any time. Well, of course, that's not what the SNS is there to do. We did make some efforts at modernization during the pandemic bill that we passed a year before the pandemic hit. That is one of the areas where I think we do need to go back and ask the questions. Did this behave the way we thought it would behave? And remember, most of our pandemic preparedness in the past was geared around a pandemic flu. And this one has behaved differently from what a flu pandemic does. So there are some structural differences. I would also say, just more broadly, since you've involved the American medical colleges, that's great. And one of the things that has concerned me during this, of course, is the availability of testing and the amount of testing capacity that is kind of sitting on the sidelines in research labs and academic labs, not in our hospitals and not in our like Quest and LabCorp, the labs that are commercial labs that are doing this type of activity, but just stuff that is available, paid for by grants from the NIH, that is sitting in research facilities and not being used. One of the things that has been done by HHS during this pandemic was the designation that, look, if you have a test that can say yes or no, someone's got a problem, you don't have to give them a diagnosis. You can refer them for further testing, but you can do that initial surveillance in a non-CLIA certified lab, so that the academic institutions that might be concerned that, hey, our folks are not CLIA certified, not necessary, but as long as you're not providing a specific diagnosis to a specific individual, as long as you're providing surveillance for a rather broad but low-risk population, this is the type of testing that I would look to our academic institutions to help us with. I think it is that day will come. Right now, behind on the testing, no question about it. It's catching up. It's been a phenomenal effort on the part of the of hospitals that have borne this burden, but they need the additional help. If it's there and it's on the sidelines, it should get off the sidelines and help.
Congressman, I've often, wondered if you were an alien coming to America to look at how our testing system was working, the directions we were getting. I wouldn't blame that alien for being very confused because, at the beginning we were sort of had protocols that encouraged testing those that were showing symptoms. But even the president's former Homeland Security advisor, Tom Bossert, said we need to have a system that tests the well, not the ill. The ill are clearly have something going on, but to get a handle of this, apparently today the CDC has walked back its guidance and said we need to go back and test those with symptoms and not there. Do you have any idea what these flip-flops are about?
Well, look, it's trying to manage just the brunt and the onslaught of the pandemic. It was several years ago where the decision was made to sort of crowd out what are called laboratory developed tests. These have been regulated under a group of laws called the CLIA amendments from the 1980s. But the FDA was going to bring those in-house and was going to regulate all of that in-house. That had the effect of driving private sector investment out of laboratory developed testing space. So as a consequence, we weren't well prepared for that. Now, what you saw in the early days, the CDC had a test. Then there were some problems with the test that may or may not have been able to be predicted. But the CDC was never going to be able to scale up to the number of tests that would be necessary for surveillance for this type of disease outbreak. And I think they will admit that if you ask them. In a flu pandemic, for example, you don't really have to test everyone. You test segments of the population to assure that you're on the right track, but you don't have to test everyone. With this disease, because of the long incubation period, because people can walk around being asymptomatic for a number of days and spread the virus before they actually become ill, this one testing becomes paramount, and the ability to test broad segments of an asymptomatic population, as you point out, test the well, not the sick. So those initial restrictions on we only will test people who've traveled to mainland China or who are exhibiting these symptoms were because they simply didn't have the testing capacity. The CDC, in my opinion, was never designed to have that type of testing capacity. Private sector was, and now the private sector is involved, and that's why you see the explosion of the number of tests that are available. The number of tests, I think we're up to 900,000 tests done per day in this country, which is truly phenomenal. But that is the type of surveillance that you're going to have. Some people argue you even need to have more testing to open up university classes and school districts. And again, you're testing people who are asymptomatic, who you don't expect to have the illness. That's the other thing when you look at the populations who are tested coming into hospital for procedures, coming in for elective surgeries now that those can be done again, the overall positivity rate in that population is extremely low. But still, it doesn't mean you don't test. The testing is going to be the bulwark of how we, until a vaccine is around and available, and a lot of people have stepped up to take it, the testing is going to be one of the arrows in the quiver.
I really appreciate your candor on that, and I should also tell our audience this is an area I pay a lot of attention to, and there's an extraordinary amount of innovation going on out there in the private sector on testing possibilities and particularly short results. We don't have them all out there deployed right now, but I sometimes think we should be careful of freeze framing this moment and thinking that's just going to carry on. There's been a lot of progress as you've intimated. We have a question for you, Congressman, from Katie. Katie?
I'm Katie Oman with the American College of Surgeons, Washington, D.C. office, and I manage our Political Action Committee Surgeons PAC and our grassroots programming. My question is, will Congress consider, or will the administration consider, additional liability protections to ensure that health professionals are fully covered during public health pandemics and emergencies like COVID-19?
They should. I think you're hearing that discussion occurring over on the Senate side of the Capitol. It was not part of the discussion. In fact, it was purposely excluded from the House discussion when the House passed the rather large bill on a party line vote at the end of May. This was not part of the discussion. Now, I know Senator Cornyn, my senator, I know Senator McConnell, the majority leader over the Senate, have said this is one of the things that we have to see in order to go forward with these negotiations. That's actually been where part of the stalemate is. And one of the things that's been really uncomfortable about all of this is there's some other things tied up in that as well. But yeah, it does seem like at this time, with these conditions, some type of certainty in medical liability would be reasonable to provide to people. It doesn't have to be enduring. It doesn't have to be forever, but at least enough to get us through this crisis. And then if we want to revisit it in 12, 18, 24 months, whatever people decide, that would be fine. But we do need part of the path out of this is people on the front lines, people who are providing the care, can't have the additional fear that I get through all this and then I'm going to spend the next 4 years with it being litigated in court. That did I do enough at the right time? That's where we've got to provide some help.
Well, Representative Michael Burgess, I bet your colleagues on both sides of the aisle are very grateful to have a medical doctor with your experience out there talking about these policy issues. Thank you so much for sharing your insights with us today.
Sure, Steve. Thank you.